What's up, future respiratory therapist? This episode is a special episode. I'm joined today by a very special guest, JJ the RT.
Absolutely. We're going to go through Coach's RT talk with the standard here. And when we talk about the standard, we've got to talk about this group of people. This group is the inaugural group of the APRT at the Ohio State. You can't talk about the standard without talking about this group. They have done things that are just blazing a trail for us and our future with this profession. So we were lucky enough to talk to them, and I hope you enjoyed this.
I hope you enjoyed as much as we did. Get ready. Next episode, RT Talk with the Standard. So I just want to take this opportunity here real quick to welcome everybody to this amazing opportunity to interview the very first class of the Advanced Practice Respiratory Therapist degree out of the Ohio State University. And so we're going to ask them some questions. We're going to learn a little bit about their journey today. We're going to figure out where they see this journey going. And we hope you learn from it. And we also hope maybe you might be inspired to maybe follow in their footsteps. These are the people that were brave enough to take the first step. And so without any further ado, my name is Joe Lewis. We know we have JJ the RT here with us. JJ, you want to introduce yourself?
Hey everybody, JJ the RT here. I don't know, not really big on the YouTube scene yet, but kind of making some pushes on Instagram. Go check it out. But I'm currently a traveling respiratory therapist in the Virgin Islands. Last night was actually my last night for about 30 days, but I'm coming back. So I'm on holiday. So I'll be looking to probably do some more things like this and just spend some time with more people in the community over the next 30 days or so.
Yeah, awesome. Thank you, JJ, for being here. If you don't know, JJ is kind of the co-host of this interview, if that's what you want to call it. You're going to see this posted on his YouTube channel on his version of the Standard. It'll be on my version of RT Talk. And now we're going to get to the most important part of all of this, which is giving recognition to the people who actually earned the degree. So we're going to start here by giving them just a few minutes to tell a little bit about themselves. Whatever they want to say, it's your time. Okay, so we're going to start here with Mindy Conklin.
Hi, Mindy Conklin. I've been a respiratory therapist for 11 years at The Ohio State University. I'm a mom of 3. I went through this program working Fridays, Saturdays, and Sundays, and I did it successfully, and it's been a fantastic experience.
Perfect. Phenomenal. Thank you so much. Next, we have Courtney Thompson.
Hi, guys. I'm Courtney Thompson. I have been a respiratory therapist for 6 years now at The Ohio State. I actually graduated from Marshall University in West Virginia before I came up here. I went through the program all on night shift, working all kinds of schedules. So I was a little bit of everywhere. And yeah, that's me.
Perfect. I love it. Poonam Shingala. Tell us a little bit about yourself.
Hi, I'm Poonam Shingala. I've been an RT here at Nationwide Children's Hospital for 9 years. I did my undergrad at Ohio State. And I do have 2 little kids. I have 2 toddlers, kind of while I was going through this program as well. And then I also, like Mindy, worked every weekend for the last 2.5 years to get this done. And yes, we can live to tell about it because we all made it through the program successfully. Yeah.
Perfect. I love that. You can live to tell about it. That is such a great statement right there. And then finally, we have Scott Hazelwood.
Hey everyone, Scott Hazelwood. I am an RT for over the past 7 years. I've been working at The Ohio State University, previously worked at Cleveland Clinic main campus. I did my undergrad at Bowling Green State University. And just like Courtney, primarily did my work during night shift, and proud to say that we all made it through and ready to make an impact.
Nice. All right. I love it. Thank you all so much for being here. I'm going to kick it off to JJ because I think he says it best when we were talking the other day. So JJ, I'm going to let you kick off the question aspect of this. What do you have to either say or to ask any of these graduates?
Absolutely. Again, thank you guys for joining us. We are truly honored to have you because this is a program that I've been hearing about for quite some time. And actually, it was on my radar to go into the APRT program at one point, but my kind of path led me more towards education now. So I've kind of shifted that from wanting to be kind of that main person at the bedside to now shifting over to education and molding the future. But what I really wanted to say is you guys are absolutely the pioneers for this program, and it is truly exciting. I am definitely excited and proud to say that I'm getting to be a part of this group right now, at least from an outside perspective, and I get to pick your brains a little bit. So whoever really wants to take this question first is more than welcome to. But when you got into this program, did you realize that you were going to be making history?
I'll go first. Not at all. Not at all. Like, that's such a loaded question. Like,
it's a great, like, it's true though. You guys are changing the mold for tank jockey to neb jockey to now.
Yeah,
come on, you can't see my hand.
Yeah, absolutely. I'll let the others speak too, but I feel like it still hasn't quite hit us. Even though we've graduated and we do things like this, it's just crazy to think that we're the only 7 with this type of degree ever in the United States. And it's especially when we have to like tell other healthcare professionals kind of what we went to school for, and we get to explain to them what that is. It's great every time we have to do it. So it's wonderful.
Mindy, what do you say?
Our professors told us that we would be making history, but I don't think it really set into us that we would literally be like the pioneers of this program to like grow our profession to a new level. So it's been very exciting. Like I told you before, just being able to care for like the whole entire patient and not just be the neb person or the person on the ventilator. It's been a really true honor.
Cool. Scott, you got something here? Oh, I'm sorry.
It's fine. I think I don't know, at Children's, I feel like the vibe is pretty electric. It's exciting. We've talked a lot about it on social media, and you guys are helping obviously get the word out there. But it's really humbling to hear high praise from other people, like our just different departments throughout the hospital, attendings, other nurses, other RTs that are curious, even some of the undergrad students that are asking us questions about it, where they're not even finished with their own their own bachelor's yet. So it's been exciting to see just how excited everyone else is. And that vibe is really encouraging. It's been pretty neat. It's kind of hard to put into words that and to think like we're the first in the country. And actually we are the first in the country. But it's also nice to see how excited everyone else is around us. So.
I may be wrong about this, but I don't think you're the first in the country. I think you are the first in the world, right?
Yes.
I mean, let's be real here. Like, let's not like try to minimize it and be like, oh, we're the first in Ohio, or we're the first in the country. 7 are the first in the world.
You do know what they call us, right?
Do what?
I said, you do know what they call us. They call us the Magnificent 7.
The Magnificent 7. Oh, I love that. Magnificent. Well, I'm going to put Magnificent out here next to this.
Yeah.
You guys need to have like your own Instagram page. The Magnificent 7.
Yeah, for sure. For sure.
Like, that needs to be a whole thing. Like, hashtag all of it. We'll get it trending.
Yeah.
If anybody can, this guy right here can.
Yeah. Scott, what you want to add to this conversation?
Yeah, I don't think it's really fully set in yet. And, I think a word that we're going to throw around quite a bit and continue to for quite a while is that, we're trailblazers. We're setting that path for others to follow us. And, it's a big, big deal. And, I know the 7 of us are really proud and honored to, to pave the way.
I think that's awesome. I think you are going to hear that word a lot. And I think that's an amazing thing. Let me ask you this question. Okay. And Scott, I'm going to leave it on you because I don't want you to have to go last every time. Okay. So we're going to start with you this time and we'll work backwards the way we came to you. Okay, Scott. So my question is this: think back to before you started this program. Okay. Would you have considered yourself a trailblazer at the RRT level?
To be honest with you, I don't think I would. Just one of the many, little fish in a big pond. And, definitely didn't think of myself as that.
Why not?
Well, because I guess nothing truly drastically would set us apart from anyone else.
Okay. Fair enough. Good answer. I appreciate it. Thank you, Scott. Poonam, what do you think?
Yeah, so I agree with Scott. Although we are all seasoned respiratory therapists, we have a ton of experience under our belt. Just being an RRT, I wouldn't consider myself a trailblazer or a leader in any capacity. However, Scott and I have talked about this a little bit. I think one of the reasons we even considered doing this program is to kind of get some of that autonomy, kind of be able to be leaders, and what kind of drove us really into this is kind of having some independence to make some of those decisions for our patients, but and kind of having a more impactful say in their care. So.
Okay, perfect. Courtney?
I might feel just a little differently than the others. Which that is a great question. I came from a very small area in West Virginia. So even just to move to Columbus, Ohio for me was huge. And I felt like I already was kind of like living out the dreams of other people, just be able to move and be a part of such a large hospital. Because I remember when I posted on Facebook when I got this job 6 years ago, people were like, oh, that's great to move to such a bigger area and work at such a bigger hospital. And they're so great at that. So I kind of felt like that from that, but it did kind of, I don't say die off, but you get kind of used to it after 6 years, but I never thought that it would be to this extent of actually trailblazing in the respiratory profession. So it's been wonderful.
Yeah. Morgantown?
No, technically Huntington.
Okay.
Marshall. So WVU isn't always friends.
Okay. All right, cool. All right. Mindy, what say you?
I kind of feel the same way Courtney does. I'm probably the oddball of the group. I didn't go to college until I was 31. So I was a stay-at-home mom, decided, hey, my kids are in school. I want to go to college. And I knew when I did my clinical rotation, I wanted to work at Ohio State. And I think that for me, I feel like a trailblazer because we do a lot of clinicals for the undergrad students and they look up to you. So I feel like you have to put yourself at a higher standard in order to teach these young respiratory therapy students the proper ways to care for a patient and assess a patient and the critical thinking skills. So I think that in the end, I feel like I am a trailblazer in the respiratory therapy world.
Nice. So I just want to throw this out real quick and I'm going to toss it back to JJ. You just said something that really hits deep inside of me. I've been teaching at the associate's degree level now for 10 years. And there's a lot of talk about moving to the bachelor entry requirement. And I'll be honest, that's not the point of this conversation. I'm in favor of it, okay? I'm not against it. I think if it helps the profession, then it's a good thing, okay? But I will tell you that I believe that if we go to a bachelor entry degree level program, I think we'll miss out on the Mindys. Mm-hmm. I don't think anybody at 31, 32, 33 is looking to go back to school for a 4-year bachelor's degree. Not none of them. So don't take me to task on that. But I'm just saying in general, the associates, did you start at the associate's degree level or no?
Yes, I did. I got my associate's in respiratory therapy and then went on to get a bachelor's in healthcare management. And I feel like I got the same education as somebody else who got their RRT.
Right. So my point is that it's not rocket science to know that you were probably about to tell me that,
Right.
because at that non-traditional level, you find people coming back to what can I get into from a career mode at the cheapest, fastest rate. And at a 2-year degree for $10,000 less, give or take a little bit, depending on where you're going, it just makes sense. And I'm so afraid that we're going to miss out on the Mindy. So I just want to say thank you, Mindy. I'm proud of you for where you started from, going back as a non-traditional student, and here you are now a part of this group. I think it's an amazing story. JJ.
Thank you.
Yeah, I kind of feel like we're doing a fantasy football draft, going up,
Yeah.
and then back down, and then we'll come back around. We're just prepping for a couple months from now. That's all.
Yeah.
To switch gears just a little bit, and maybe a little bit more superficial conversation, just kind of take the air, take the heaviness away from the room and the conversation. But where do you guys plan on working? Adult, peds, clinic, ICU? What's your plan there, Mindy?
I really enjoyed my outpatient experience. I'm not against working in the ICU at all. I'm really curious and very interested in pulmonary hypertension. And I do know that could be a couple opportunities for us there. And I kind of found outpatient sleep to be one of my favorite rotations. So I could see myself going outpatient.
Nice.
Yeah.
Courtney?
I also really liked my outpatient rotation. I went into clinicals when we started 100% into inpatient and knew exactly that's what I wanted to do. And then I think clinicals in the outpatient world, I was like, whoa, what have I been missing for the past 6 years? So I think definitely outpatient could be the place for me. Sleep medicine was definitely, kind of to mimic Mindy, a great rotation. But I'm also not against working in the ICU or inpatient as well. So it'll be kind of interesting to see what I decide to choose, but could go either way, honestly.
Poonam?
Yeah. So similar. I think I'm the only one on here that works at Children's. And no offense with adults, love them, but I work a lot harder for the kids. So I will continue to stay at Children's. It is my home. And I think for me, I have a hard time kind of narrowing down where I want to be at. I really enjoyed pulmonary outpatient sleep as well. But I liked kind of the both together. As well as if I had to work inpatient, I'd like to be inpatient pulm. It just resonated. I like the atmosphere. I like the patient profiles. And yeah, so we'll see right now. Things are still in early conversations right now, and we'll kind of go from there.
I wish I would have known you guys were so interested in sleep. Monday, I put on a sleep workshop for the Texas Society of Respiratory Care, and it would have been amazing to have you guys on. I've been planning this stinking thing a committee and I have been planning this thing since the beginning of the year. And if I would have known that you guys were so interested, that would have been so much easier. Oh, we got at least 3 speakers here. We're done with half of it, but that's awesome.
I was thinking the
Scott,
same thing, JJ.
Yeah. What do you say, Scott?
So I would like to be in the adult patient population. And what really I enjoyed the most was pulmonary consults in the inpatient setting. And, if I could maybe do that with a combination of pulmonary outpatient clinic or maybe a combination within the medical ICU, I think that would be a great fit.
Nice.
Awesome. Yeah. Not to put myself in there, but if I were to go into the program, I probably would find myself in an ICU. I just like that setting. I could have used you last night, Poonam. I went to my first C-section ever. Those little critters, they're not for me, but I like my adults.
I'm gonna ask Poonam a question here real quick, because I really want to know. Why do you work harder for pediatrics than you do adults?
Because I don't have a history. right? They haven't done anything yet. They haven't smoked any cigarettes. They haven't destroyed their livers yet, with alcohol and things like that. So for me, I kind of see it as they're brand new. And I want to give them the best shot I can, in terms of whatever I could do to help them breathe, right? And we do that every day here. And so, I don't know, plus they're really cute.
So let me ask you, you're in a hot seat right now, just FYI. So do you think pediatrics are more deserving of better quality care than adults?
No, not by any means.
That's what you just said.
What I mean to say is they don't have a history. They haven't,
they also haven't contributed to society.
But they were just born 5 minutes ago, right? So
okay.
we want to make them upstanding members of society by giving them a chance to breathe.
I got you.
Poonam, you're on the hot seat because that's a hot button for Joe.
That's a hot button, man. Anytime, I'm sorry, I'll work hard for anybody, but my love is in the adult world, and it drives me crazy. It really does. And this is not anything to you. I'm not talking to you right now, Poonam. I'm really talking to everybody who might be watching. It drives me crazy when I see the quality of care in the pediatric world and the neonatal world is so up here, and then the adult world is so down here. Well, why do you have so many staff members? Why are you the biggest hospital in the area? Because you're a children's hospital. Oh, because we do one-on-one care. Well, that's not even an argument. Did you really just say that as a manager? That doesn't even make sense. Anyways, Scott, I got a question for you. This is not about me. This is about y'all. So let's get back to y'all. Scott, here's the question I have for all of you, but we're going to start back here with Scott. So I'm curious to know how you see this platform. Do you see it as a platform to move out and continue to promote and advocate for, where do you see the RRTs in your role? Are you going to be an advocate for them, or is this like a move into an advanced practice degree, and now I'm in this role and I've suddenly forgotten about where I came from? What do you think about that?
Well, we're certainly going to be an advocate for an RRT. We were there. We, are still there, but at a higher level. But not only are we going to advocate for those bedside respiratory therapists, but, we're going to advocate for those bedside nurses. We're going to advocate for those bedside residents who may not be fully aware of how a ventilator works, how a certain mode may work, and why, we're doing what we're doing. And, we are a head to toe profession. And, so we're advocating for anyone who is going to care for that patient from a head to toe standpoint.
Nice. Was there talk in your program as you went through it? Was there talk like let's say you're in the ICU and you're trying to manage mechanical ventilation. Is there, I'm trying to get a feel for how this relationship is going to work between you as an APRT and me as an RRT. How's it going to look? What are we going to be standing at the ventilator together, or am I going to be calling you going, hey, come look at the patient? What is this going to look like?
I feel like it's a communication. So if we were in rounds, I would want to be with my respiratory therapist and go over, what is a plateau pressure? What can we do to wean the patient from the ventilator today? I just don't want to delegate to them. I want them to be involved with the care also.
Yeah, I think so too, that it's about almost creating a support system, because you work at such a big medical center. I feel like sometimes respiratory is not heard. So I feel like this is our chance to get this advanced practitioner up into that role to really speak for the respiratory side of things, because so many people assume that, oh, this is what they do in respiratory therapy, and then it's actually the complete opposite. They're making decisions because they think they know what we do or how we work. And I think another big area for us as well is to help create protocols or guidelines or kind of those things to work with RT to do that. There's no reason why we can't have a lot more protocols and stuff for the RT to operate at the bedside like nursing or anyone else has either. So I think that is going to be a huge relationship too. Mm-hmm. And I think it's going to vary between inpatient and outpatient. Inpatient, I can see all the things we've talked about happening. Outpatient, outside of our PFT lab, we really don't have any RTs outpatient. Like in the sleep, outside of sleep, happen in the actual sleep clinic, there's not any respiratory therapists there kind of like helping with the patients and that kind of thing. And that would be a perfect place for people. So I think definitely advocating for that too would be huge.
Nice.
Yeah, I think while the RT, we are still our RTs, and I think we all chose to become APRTs because we didn't want to get away from our profession, right? In our industry of wanting to jump ship and go do nursing or go do become a PA or things like that. So for us to continue to support the RTs, the bedside RTs especially, kind of working in a collaborative way, and also educating. We all work for teaching hospitals. So a big role of what we do every day is teaching, right? Or precepting or orienting in some capacity. So we can orient and precept across the profession as well. So we sometimes will have a med student that we do a lecture with, or we do precepting of nurses and things like that. So already we're a collaborative group. And so I think continuing that, as well as, yeah, I agree with Courtney, the setting would look different and your role would be different as an APRT. Maybe outpatient, you're doing a little bit more kind of direct ordering of things and protocols, treatments, therapies, things like that. Inpatient, it might be more rounds, again, more orders and things like that, but you're still communicating efficiently with the bedside team, right? That's the whole goal, is to kind of tie some of these things together across the spectrum.
Nice. Very good. Scott, you want to follow up on this, add to it?
No, I think what everyone said was pretty on point. And Poonam makes a great statement about, collaboration between everyone.
Yeah, for sure. Collaboration is something that me and JJ talk a lot about, man. You can probably see him smile here in just a second, not because I cued him to smile, but because he knows that we, over the past several months, have talked more about collaboration and the need for it. We're never going to get to where we want to go if we don't join arms with PT, OT, speech, nursing, dietitians, pharmacy. I mean, it's just all about collaboration. It doesn't feel like we're there yet, but it feels like we might be getting closer to getting there. JJ, you're up, man.
Yeah. Another kind of fun topic that I kind of am interested in is, I know you guys are going to be able to do procedures and diagnostic things. Which one was the most difficult for you to learn, and which one was the most fun?
I think the most fun one that pops to my head is learning how to bronch. A lot of fun, because I think as a bedside RT, especially in the ICU for the past 6 years, I've assisted with so many, like I've lost count, but to actually be able to be the one that drives and does things like that. We did interventional pulmonology clinicals as well. So we were able to do like the EBUS, stents, like that kind of thing. So that was super cool to learn. And every time we got to do it, it was great. I don't know about the hardest one. I don't know. I think still to probably, I don't know if there's a hardest one. I think I enjoyed like all of them, just being to like step up and do like just such an array of procedures that it was fantastic. I think the one that still probably makes me uncomfortable, we'll use that one a little bit, is maybe like a chest tube type thing, because in my head that's such a big thing. But that's probably, bronchs were my favorite.
AJ, I think you stumped her. I think you gave her the one quiz question she couldn't answer.
Hey, I'm not. That's not what I'm here for. But I'm just here to get some smiles, and apparently that worked.
Yeah.
Mindy, what about you?
Did you say Mindy?
Yeah.
Oh, I agree with Courtney. Bronx is really awesome to do. I got to do a lot of Bronx during a trach. And, you know, we're usually the one holding the ET tube so we don't lose the tube. So it was really cool to go down and be the one in control of letting the resident or the attending or fellow be able to trach that patient. So I thought that was the fun part of it. For me, central lines it was more made me nervous than anything because you had to hold the ultrasound and you had to push in with the needle the same time you pull back. So coordinating, you know, your ultrasound and your needle for insertion was a little nerve-wracking. I wouldn't call it scary. It was more like, please don't give this patient a pneumo. But that's what I enjoyed. So,
Now you're speaking my language.
yes.
Yeah.
Just a little background on me. I was part of a group in Texas who started doing central lines. And that was almost a week of hell learning how to do central lines. But once you kind of got those first handful, dozen under your belt, it's a whole different world. And it's such a fun tool. And ultrasound, we'll get into ultrasound next. But Poonam, what do you say about the most fun and most difficult or challenging?
Most fun. I think I had the most fun in two different settings. Yes, the Bronx were super fun. But I really like getting the critical ENT, kind of the anesthesia airways in the OR. Because there's nothing more difficult than some of these airways, and I was able to get them. So that was a lot of fun. It was really rewarding to do that. The thing that still makes me so nervous and uncomfortable is definitely the central lines. I could talk you through it, but I still get a little nervous trying to do that. So
start playing video games. You'll get better at it.
Yeah.
There's a study link that links the two. It's really crazy. But yeah. Scott, what you got, my friend?
Yeah, so I think the best was probably a bedside thoracentesis. It was ultrasound guided and, you know, able to pull off all that fluid while the patient was sitting upright and awake. And, you know, just seeing all that fluid being aspirated out into a larger bag and close to like 3 liters was, you know, pretty satisfying. And you know, a great rush to be able to do that after seeing so many. And then, you know, just kind of echo what Mindy and Poonam already said. Yeah, central lines are just a whole different thing. And, you know, when you're done, it's, you know, you're not done from there. Then it's, you know, getting some sort of imaging done to make sure you're at where you need to be and, you know, checking for bleeding from the site. And, you know, there's just a lot more to it than, you know, many may think.
Absolutely. That was kind of one of the fun things, and kind of the feather in the hat moment, right? Is RTs being able to do central lines. I think we need to give our kudos to Banner Health out in Arizona. They're the ones that pioneered that. But I think there's 13 different states that have RTs doing vascular access now. There's not a quote unquote scope of practice that says it's out of our scope. So definitely that is something that I'm a big proponent of, is advocating for that vascular access. Joe, you got something? I'm going to follow up with ultrasound after yours.
Well, I've got one more question and I got one more thought, but I'm going to ask the question first. Scott, I'll start with you because that seems to be the trend here. My question is when I watched the RT to PA's interview with Courtney, you made a statement that was something revolving around this. I'm not going to quote you exactly because I would probably mess it up and I don't want to put words in your mouth. But you essentially said that you were looking to build the trust to let you and your cohort to find the data to show what your value is. Okay. So my question to each of you is, What is your number one goal when you talk about finding data to prove value for RT? What is it for you? Scott.
That's a great question. You know, I think just as a whole, I think if we're able to show some sort of a percent of maybe if we're intervening and, you know, able to do some sort of procedure maybe a little quicker than normally, that, you know, if we can decrease any sort of mortality rate within the hospital setting, I think just, you know, increasing life is just our main goal as a healthcare profession as a whole.
I agree with that 100%, and we'll clap and yeah. But I think the question is do you have anything specific that you like are interested in studying to show data on? Nothing specific?
You know, that'd be something that I'd have to think about. I think
Okay.
I'll pass that along to my cohorts.
Okay. All right. Poonam, what do you think about?
I want to say, yeah, I kind of want to piggyback a little bit on Scott. Also, yeah, we're trying to improve mortality. However, at the same time, one of the things that we've learned during our program is the business side of medicine, right? So also, how does that impact your patient? How does the hospital stay afloat? One of the challenging parts of our program was going through and learning all of this stuff while we were in the middle of a global pandemic, seeing how all of that was also taking its toll on the hospitals and things like that. But one of the things that I want to, my master's project was on pediatric sleep. And so it was like telemedicine and CPAP adherence with pediatric and adult patients. So for me, I want to personally take that on and kind of keep going with that research to say, okay, like if I was a champion of non-invasive mechanical ventilation, which there's no one that knows it better than we do, right? We just know that as a profession, sure. No one knows it better than we do, and no one can explain it as well as us. So if I were to take that on, how would that impact an outpatient practice? How would that impact access for my patients? Could they get a hold of me quicker? Do they always need a physician provider? How does all that look? And so some of that stuff I talked about in my master's thesis, but I kind of want to put it into practice as well and see just nice. How does that get together.
I have a really good contact over in Pennsylvania. He's actually, like, I don't know, like, you probably can, because you probably got greater contacts than I have. I only have one contact that is involved in telehealth. Mm-hmm. But if you're interested in that contact, send me a message. I'll get you hooked up with them. Maybe able to help you with that project. Courtney, what do you say?
I think, especially in that interview, what I was talking about, mainly is, so I currently in my RT role, I'm actually the team lead for, so I'm like 60% clinical and then 40% doing a lot of education and stuff. So I work already a lot with extubation time. So seeing how quick, like once the patient passes their SVT, how quickly they can be extubated. And it's not as quick as what we thought it was going to be. So I think that is a huge place for APRTs to make that decision, because we can re-intubate them if they fail, and we're kind of like the fail safe for that, so it would be a nice spot. And then I think also too, really, I hate to keep saying NIMV or CPAP BiPAP, but sometimes it gets so confusing, especially with residents and then certain fellows as well. Like they just don't understand the overall picture or how to truly manage it. They may know what CPAP is, what BiPAP is, but they don't know IPAP, EPAP. They don't know what C-flex is. They don't know all of those things that go along with it to help better manage that patient. And they're quicker to jump to other therapies or more invasive therapies because they don't know how to manage that. So I think it would be cool to see once we start practicing, kind of how that affects the management of certain respiratory things.
I love that conversation right there. I mean, that JJ, we were talking about this last night. It was like, I asked JJ last night, I was like, why do residents choose vent modes based off of what team they're on? If you're on surgery, you're going SIMV. If you're on medicine, you're going AC. And if you try to do something outside of that box, oh, you're done, right? It's so important. That's such a true, I like that. I like that in you guys having a hand-to-hand role, because, I mean, let's be honest, they will respect you more because you are seen at a higher level than the bedside RT, which is not a diminishment to any bedside RT. But the truth is that your practice and your degree is seen as a higher level. So maybe there are waves to be made in that right there. I would love for all of you to connect with your closest university to teach the med students that that's stupid. Anyways, Mindy, go ahead.
So for my capstone project, I was looking into ultrasound. And since we were in a global pandemic, I chose to study the how we can use ultrasound in the outpatient setting to monitor the residual effects of COVID. So I would like to look into more if we can monitor the patients who are in the ICU with a lung and cardiac ultrasound, and then because we're going to have like an outpatient clinic for COVID here eventually, and then send those patients to the outpatient clinic and be able to follow up like a 6-month to yearly follow-up on their cardiopulmonary status from COVID to see if there's any changes in their heart or their cardiac function, so we can treat them.
Cool. I think that's phenomenal. And I know JJ is going to jump all over that in just a second. I want to give Scott, because I think I might have shortchanged Scott on that question, kind of blindsided him with it. If while everybody else was talking, have you thought of anything else you wanted to say on this, or are you good?
I guess to continue, focusing on, our capstone thesis projects, what I did it on was the use of ketamine as an induction agent versus other, induction agents, and whether or not that can be used more primarily as opposed to the typical induction medication like etomidate. And I think just, kind of looking at that data and, if there's any support to show, again, going back to decreasing patient mortality or comorbidities, is just, something that I would like to continue to focus on.
Yeah, I'm with you on that. So JJ, take away your ultrasound stuff. I know you're about to go there.
Absolutely. So I'm like itching to talk about ultrasound, because in my experience with ultrasound started with the central line stuff, right? The practice of the RTs placing central lines. And then it expanded to, post line insertion to doing a pneumo screen, right? With the ultrasound. Now it's expanded into doing a whole full chest examination, cardiac exam, and going through the Blue protocol and things of that nature. And some of the conversations that I've had with Joe is, at some point, I feel the ultrasound is going to replace the stethoscope. What say you? Anybody? Coin flip, ready, go.
I don't know if it'll necessarily replace the stethoscope in certain situations, but I can see how
Boot her out.
Ultrasounds.
Boot her out.
Do I?
I'm just playing. I'm kidding. I'm just kidding.
Well, there's,
go ahead, Mindy.
I mean, in certain settings, I can see that could replace a stethoscope. But like if you're just doing like med surg patients, I don't see that necessarily the need for it. But like the outpatient world or bedside assessment in the ICU, if you want to see if they're fluid overloaded, you don't need to listen. You can just look to see if there's consolidation or fluid in there. And then also with pneumonia, you could see those areas of consolidation on an ultrasound.
Nice.
Yeah.
Yeah, I think I could, in certain situations, see ultrasound taking a for the stethoscope for sure, especially with cardiac and pulmonary, especially just because there's so many things you're like, well, like, do I hear breath sounds? Do I not? Is that there? Like, how do we double check? And guess what? Ultrasound that we can just roll right up to the bedside can tell us most of the time yes or no. And if not, then it leads us to go another way to figure out the answer to our question that sometimes just a stethoscope can't. But I do think it's important that we don't lose the stethoscope skill in a way to know how to like quickly assess if there's not an ultrasound readily available.
Bye, Poonam. Thank you for being here. She had to go. So
she ran away from the question.
She had to run. She didn't want to answer the question. You got her, JJ. Scott, go ahead, man.
I think it can be a mixture of both. You know, with the evolving use of technology, you know, we can plug in a ultrasound probe adapter into our phones and, you know, check out, you know, what the patient has going on just that quick and easy. But at the same time, you know, if we are extubating a patient and, you know, there's concern of any sort of upper airway stridor or edema, you know, that readily available and go-to stethoscope is, you know, it's hard to match. But I definitely think that there is, you know, there could be a use for both in our world.
Absolutely. I actually have one of those that I can throw into my pocket and I take it to the bedside, and used it for a patient that had pleural effusion last night and assessed them for fluid overload myself. So when you were talking about that thoracentesis and then assessing, you know, fluid overload and things like that, I was like, oh yeah, I got to put that into practice last night. So it's just really cool to see the technologies that are available and the progression of where the profession is going. It just truly excites me and keeps me engaged. But I think I've been kind of peppering you guys with the jabs. I'll let Joe come with another heavy hook and see what other questions or thoughts he has.
Well, what I'm going to do now is I'm going to recap everything that's kind of been said. If you'll engage with me for just a second. These are the areas of interest that y'all have talked about. I think these are all great areas, talking about the use of ketamine, ultrasound, extubation times, and how can we reduce those? How can we get them quicker? How can we get people off the ventilator quicker? I love that. Pediatric and sleep, along with telemedicine. And look, if you're not on the telemedicine train, then you're stuck at the station, because it's coming. It's already here, but it's coming, and it's going to be a big deal. I love the ideas of, you know, getting involved with procedures and decreasing mortality, and you 7. We're not just talking to the 3 that are left with us right now, but the 7 of you who graduated of seeing a role in that. I love the fact that this right here came up in this conversation. Like, you're actually going to talk about decreased mortality because you see you have a role in that. And I love that concept. If you know anything about me, you know I'm a big patient advocate. I'm all about what's best for the patient, whether it's peds, even though she's gone, or adults. It's still, it's all a human life. And I love all things that reduce mortality and reduce morbidity and get patients out of the hospital quicker. I love that. The bronchoscopy seemed to be the most exciting theme or the funnest to learn from you. So I envy you in this, because I would probably agree that that's super exciting to get to run that piece of equipment. The thoracentesis was another exciting moment, but then the flip side of that was the central lines being super scary. So that kind of puts that into perspective. I love this statement right here when we talked about advocating for respiratory therapy going forward. And forgive me if I get this wrong, but I think Courtney said RTs are not heard. And I think that's so true. I think we have ownership to take in that. I think we've messed up for many years in leading to us not being heard. But hopefully U7 can somehow begin the process, along with what a lot of other people are doing well out there, to get RT's voices up and heard, so that people realize that we do have an impact to make, because I think that's valuable. Continue to advocate for the profession. The autonomy seemed to be kind of the underlying theme of what led you into this, looking for more autonomy. You wanted that level of being able to make decisions. I think that's a beautiful thing. I don't think there's any respiratory therapists out there. As a matter of fact, if you ask me, when it comes to job satisfaction, I think it comes down to two things: control of schedule and autonomy. That's what I think the two biggest things are. I don't even think pay has anything to do with it. I think it's scheduling and autonomy. So I agree with this 100%. A lot of these words came here early: pioneers, the Magnificent Seven. You guys are trailblazers. Like, you know, it's going to set you apart from everybody else. And you should be proud of yourselves, because you've done something that no one else has ever done. And I don't care how big or small anybody thinks that is. The truth is the first person to do anything should be rewarded and should be applauded. And I applaud y'all here today. So Magnificent Seven, we're so happy you're here. My last question for you is, when I say at the end of every one of my videos, average is easy, what would you say to respiratory therapists with that in mind right now?
I think it goes back to not being heard. Like, it's easy just to sit back and not fight or not put your stuff out there and just clock in, clock out, do your job. But average is easy, and who wants to be average? I don't want to be average. I want to be a trailblazer. So
nice. Mindy?
I say the same thing Courtney is. Who wants to sit there and just listen and not speak up and have their voices heard? We're here to advocate for the patient and for our professions. So, you know, let's trailblaze down the road.
Yeah. Scott?
Yeah, you know, done being average, done with things being easy. Let's keep things going. Let's push things to be harder. You know, we're more than just button pushers. We're more than just throwing nubs at people. You know, we're way more than that. And, you know, we're going to start things and show everyone that we are.
Yeah, I love that. Every single word y'all just said, I absolutely love. My mic is hooked up to a podium here, but if I could drop it right now, I probably would on the end of Scott's words. We're done with nebs. We're done, not done with nebs, but done with being viewed as that's what we are. Yeah. Oh, you're a respiratory therapist, you give nebulizers. I mean, that's 15% maybe of what it is, right? But there's a lot more to it. And so I think we've got a long ways to go, but I'm so thankful for U7 for doing what you did. And I hope that this can spring into where we can become regular contacts, so that I can help you however that looks, and you can help me however that looks. Because the students that I'm teaching now need to know that this is an opportunity, and they need to know that it's doable. I mean, can I just reiterate this for just a second? I'm sorry, JJ, I know you're ready to talk, but give me just a second here. I always talk too much, but that's okay. We have on this segment right now, we have Mindy, who is a mom of 3 and killed it. We have Courtney, who worked night shift throughout the program and killed it. We had Poonam on here, who is also a mother of 2 and worked night shift and killed it. And can we just say that, like, whenever you think something feels impossible, like I can't do it, that's where you lost. That's where you lose, is with somebody telling you it's not that simple. It is that simple. Just do it the way you 7 just did it. And I'm so proud of you. And I'm going to let JJ wrap us up.
Well, I mean, you hit the nail on the head right there when you said it was just that simple, right? And some of the things that we've been talking about recently is just be better. right? Whatever that means for you. If that means being a better, spouse, son, daughter, mother, whatever that is, just be better. If it's a respiratory therapist, clinician, nurse, whatever that is, just be better. And you cannot grow unless you get outside of that comfort zone, right? I'm sure for every one of you, you had to make a sacrifice, and you get to smile now because you're reaping those rewards, right? And one of the most encouraging word for me in the English dictionary is impossible, because when you split that word apart, it says I'm possible, right? And that's exactly what you guys did. You made it possible. You fought through every piece of adversity to get to this point, and we are so proud of you, and we just cannot celebrate you enough. So thank you, thank you, thank you.
Yeah. I failed to mention on the backside of that Scott as well worked night shift through the program. So Scott, I didn't want you to think that I was leaving you out. JJ, if you don't have anything else, I'm going to leave it to, we're going to go Scott to Mindy to Courtney to take us away here. So any final thoughts that you have for any respiratory therapist, nurse, anybody who might be watching this? Scott, you got any final words?
Well, I just want everyone to know that if you want to do this, you can do it. And, let's spread the word. Let's everyone know what we're doing, what we want to do, what we can do. And, let's just keep things going.
I love it. Mindy, final thoughts?
Same thing. We need to spread the word across the United States to every state that we are needed. The population, the baby boomers are getting older. We need people who are specializing in cardiopulmonary to care for those patients. So, we need to bring it up to a state level and be like, hey, we need this. We need APRTs.
Nice. Courtney?
I think on the last note, I think people are so quick to tell us why this won't work or why the downfalls of this. And I just cannot wait to show them wrong. And anyone who's interested in being is a respiratory therapist and wants to be an advanced practice provider, just don't let that stop you. Don't let other people's negative words or thoughts or, well, you didn't do good in this, so can you really do that? Just go do it. Just try it, kind of back to your do it thing. I love that. Just go do it. You never know until you try. So just
tell me I can't, and I'll show you I can.
Exactly.
Well, I'm going to speak on behalf. I think me and JJ here, we are so thankful that y'all joined us today. I've thoroughly enjoyed this. I've enjoyed just getting to know a little bit about each of you individually. Just hearing about your journey, hearing about your interests, hearing about how you relate and how you think about respiratory therapy. It's been a privilege and a pleasure for me to listen to. And I'll let JJ close it out.
Well, I thought I closed it out already with the I'm possible, but
you did.
I mean, we'll do this again. Take two. No, but again, it has truly been a pleasure and an honor to have you guys. Again, just all the trailblazing, the history making, everything that you're absolutely doing. We are so proud of you, and you have fans all the way in the Virgin Islands, in Texas, all over this United States, all over this world. Anytime you guys want to connect, me and this goofball over here do a show on Instagram Live called The Bridge. And that's what we're trying to do is connect. We're connecting respiratory therapists to nurses. We're connecting students to practitioner, maybe that complacent practitioner to then find some fire again. We had some people from India, Ireland, Canada. We've had people from all over the world just kind of join and chat with us. And all we're doing is having more conversations like this. So anytime you guys would like to join us, you are more than welcome, and we would welcome you with open arms. So
we would love to. And thank you guys for giving us this opportunity to come and talk to you and get the word out there on this platform. So thank you guys so much as well. You guys are great.
Yeah, you're very welcome.
Thank you very much.
You're very welcome.
Thanks, you guys.
Scott, JJ, appreciate you guys as always. You guys will be great.